Welcome back to the exam room. Today we're diving into an inspiring conversation with Altaf Ibrahim, whose extraordinary journey from a plastic surgeon in Pakistan to a leader in preventive health in rural Arizona is a testament to resilience, compassion, and innovative thinking. Tune in as we explore how Altaf's unique experiences have shaped his powerful approach to healthcare. If you're passionate about meaningful patient care, this episode will touch your heart and inspire action.
In this episode, we will be shining a spotlight on one of our partnering health centers that's achieving great success in their breast cancer screening performance. Today, I am joined by Altaf Ibrahim, Director of Quality of Sunset Health, and they're located in Yuma, Arizona. Thank you so much for joining us today.
Good morning, Rhiannon. It's a pleasure.
Thank you so much. So before we get into it, tell us a little bit about yourself and your personal journey in this space.
So, Rhiannon, by training, I'm a medical doctor and from my home country, and I'm from Pakistan. And there I was working as a plastic surgeon. That was many, many years back. Of course, in plastic surgery or burn surgery, we do have very high mortality, especially with accidents, gunshot injuries, and burns. Now, the kind of burns that I had to deal with were mostly in low-income group families where the ladies used a primitive cooking stove. It was a Primus stove. Now, the original Primus stove was invented in Sweden in the late 1800th century. And over the years, cheaper imitations came. It runs on kerosene oil, which is the cheapest fuel available in third world countries. And you have to prime the stove, so you build in pressure by pushing some sort of a nozzle or some sort of a pressure device. The result of all that is it explodes, and whoever is nearest gets burnt severely. So we had a lot of mortality, and in burn surgery, if somebody has, say, 50% burns, the chances of that person dying is 50%. 40% burns, 40% chances of dying. And the deaths are due to infection and skin grafting. I would do for free, I wouldn't charge patients. But the cost was of electrolyte replacement, and it was exorbitant. With Pakistan being a very poor country, and especially 35 years back, it was even poorer. Very dismal, disappointing situations. I tried to do something, tried to see if I could use some of my resources and help those who made such stoves do a better job. But it was not very well accepted, that sort of an advice. The law and order situation was also getting pretty dismal. My late brother, one of my elder brothers who lived in America, he sponsored me for US immigration, and I came to America. Initially, I tried to get through the medical boards. I could not do it. My brother paid all my fees, and he kept me in his home for 10 years. That was very kind of him, and those kind of things you don't see happening anymore. People keeping you in their house for 10 years and allowing you to take exams and studying. When I couldn't pass the medical boards, I went to school, University of Detroit Mercy. And in those days, in the 90s, we had regular classes. Online schooling hadn't started yet. That particular university runs under the auspices of the Religious Sisters of Mercy. It's a religious order originating from Ireland, and some of the faculty members were nuns. I did very well in that program. I graduated with top honors. Sister Mary Kelly gave me the highest grades. Now, the thing is, here's this person who couldn't pass the medical boards, yet finished at the top of the program in health services management with a master's degree. A person who has no healthcare experience of the United States and is competing with mid-career professionals. But I did it. So Sister Mary Kelly asked me, well, you've passed, you've done exceedingly well academically. What do you want to do? And I said, I want to do chronic disease management. And I did my internship in community education and outreach with a focus on chronic disease management. Most of my work in the US has been in federally qualified healthcare centers. Now, I have seen both sides. I have worked in a very large organization which had 1,000 doctors, and our offices were in the Ritz-Carlton in Detroit, and all chrome and glass and glitter. And I've also worked in very, very remote rural clinics where all I had was a desk and chair and some associates working with me. So I think the rustic rural setting appeals more to me. And that's how I'm where I am today. This is a higher calling. Everyone cannot work in an FQSC. You have to have some spirituality, some belief that we are doing something good for the people that we serve. Because you don't have all the resources. You have to be very proactive and think out of the box and make do with a shoestring budget and try to achieve what is difficult to achieve. But I enjoy my work.
So I think when we were talking previously, you said that you've been with Sunset for 7 years. How did your experience in Pakistan and your training up to that point helped prepare you for your role as Director of Quality at Sunset?
Well, my focus has always been on prevention and preventive medicine and chronic disease management. The program at Sunset Health was developed by Dr. Wang, our Chief Medical Officer, 16, 17 years back. And I came in midstream. So they already had a program going, and I just worked with him and worked with our peers and other team members and finessed it a little bit more. America is aging. We are and there is a resurgence of chronic diseases, and also resources are shrinking. So the best thing to do if we want to save future generations is to focus on prevention. The other piece of it is the challenge that we have the most expensive healthcare system in the world. Yet we have these large pockets of underserved patient population, and even in the cities, the care is heavily dependent on expensive investigations, and also there is a lot of legal issues. So the malpractice coverage and all those kind of things. So if the goal is to have a healthy population, and we are planning for a long time, if you are planning for 1 year, you plant rice. If you are planning for 5 years, you plant fruit trees. If you are planning for 100 years, you try to educate human beings and make life a little better. So ours is a 100-year plan. And we are going to make sure that we have another set of leaders, coaches and mentors ready to take over.
Yes, absolutely. So I like what you said about, prevention and how we need to kind of shift our focus to that. And that's really one of the key pillars of value-based care. So I want to shift the conversation here a little bit and just talk more specifically about the population that Sunset serves. You mentioned an aging population here in America where we have shrinking resources, very expensive healthcare, and also patients that are living a lot longer and they have multiple chronic conditions. What are some other demographics regarding the population that you see at Sunset?
Well, Sunset is in Yuma, as you know, Yuma, Arizona. And this is a farming community. It's an agriculture-based economy. So most of the people are working in the farms, in the fields, in agriculture, and they are not making tons of money. This is a low-income population. So some of the facts about Yuma is that Yuma is the producer of iceberg lettuce, and it's the biggest producer of iceberg lettuce in the United States. So all the lettuce that we eat, the fresh vegetables, most of them are coming from Yuma. In terms of the healthcare and some of the disparities that occur in this part of the world is that Yuma had the dubious distinction of being the epicenter of the COVID pandemic. When we had COVID-19 hit us, the highest incidence rate in the world was in Yuma, Arizona, because we are very close to the border with Mexico. Sunset Health did not close down. We kept our doors open. Some of our associates dropped dead in the line of duty. I had lost a team member, other departments lost members, but we did not close down. That tells you of the resilience and the potential that is there in the associates who work at this place. We have been around for more than 30 years, and we have put together, developed teams of individuals who are highly professional, highly dedicated, and focused on providing good care. With all that being said, since this is a rule setting, the people that my team interacts with, the chronic disease specialist as we call them, these are all people who love to talk on the phone. So, you see, we do artificial intelligence too. We do try that kind of stuff, but it's the phones, is the personal connection that helps considerably in the work that we do.
I'm here to pick your brain about how well you guys are doing with your breast cancer screening performance metric. How do you think the things that you just mentioned, like resilience, dedication to good quality care, how does all of that factor in to your success with this specific measure?
Currently, the team that I have, out of the 11 people, 9 of the individuals I have hired myself over the course of the years. And I have coached and mentored them into high-performing professionals. I've done that by treating them with respect. They are not my staff, they are not. They are my respected associates. And we treat them with respect. We treat them at an equal level, and they give us 110% of the time when they are with us. You see, you can easily lose your associates if you do not bond with them. The bonding is critical in the development of a balanced team of professionals. I do not micromanage my associates. I let them develop their own ways of how they would break the ice, start a conversation with a patient. Most of the patients know them by name by now, all day long they're calling. It is that bonding, the focus on outcomes, and also learning from them, learning from your team members about the culture, and if recognizing them for their successes, giving them some incentives. An incentive may not have to be necessarily be cash, but incentive in terms of respect, allowing them to express their views freely. If they have something that they feel is not going wrong, it's not going the way it should, then they have an opportunity to share their concerns with me without fear of retaliation. If your team members are afraid of you, then it's not going to work. If you are leading and nobody is following, then you are just taking a walk. That's what it is. They are a good group of people. They have done wonderfully well, and I think it's because they have a very peaceful serene environment. I wish I could show you my the bigger office, the hall where my associates are sitting, but we have a little tree that has lights on it, and we turn the lights on in the morning. All those things help. The environment helps. If all you have is bare walls and all you tell them is just do your work and leave, and that's not going to cut it. So these little things, developing a culture of goodwill, trusting your team members. I cannot listen to every phone call they make, but they know that I trust them 100%. So it's all about trust, and trust doesn't come easily. It takes time to build trust. It's a good team, and I don't want to take unnecessary credit where credit is not due. Dr. Wang thought about putting together this sort of a program 15, 16 years, 17 years back. People have asked me, like you are asking me, others have asked me the same question, how did you do it? How did you accomplish this? Well, what you see today is the effort of 25 years. It did not happen overnight. Yes, I have finessed it. I have taken it to another level, but my predecessors did the best they could.
So all of those things that you're mentioning are great strategies for any health center, let alone any business, to implement, right, with their teams, that coaching, mentoring, trust, autonomy, respect, all of those things. Would you say that historically the breast cancer screening performance metric is difficult to achieve? And if so, why?
It is difficult to achieve, one, because of the lack of understanding of the patient population of what this is about. Breast cancers are one of the highest causes of mortality in the female patient population. Yet our patients do not understand the significance of prevention. Second, those who are in the driving seat, we sometimes think that if I send out 10,000 text messages, my work is done. It's not that easy. It doesn't happen that way. So we have to bond with these patients. There are several steps to the strategy, and we follow through and make sure every patient is accounted for. Now, also, that's why I go back to my earlier statement that working in an FQSC is a higher calling. So if your intent is just to collect a paycheck and not care about the patient population, or worry too much about the bad air conditioning or the fact that you are in too rural or too remote a setting, then this is not the place for you. You can make a reasonable income, but more than the income is the sense that you are contributing to a greater good. And I think, so our thought process, one of my associates somewhere mentioned to me, well, we send out 10,000 text messages every month. I don't know if that's going to be too useful. Not in a rural America. Maybe in the cities, not even in the cities. You do have to connect with the patients. You do.
Right. So you mentioned that there are several steps to the strategies that you're using to be successful with breast cancer screening. Can you walk us through kind of a high-level overview of what that process looks like?
Yes. So we get a listing of the patient from different plans. And then the chronic disease specialist, as we call our 9 associates, they call these patients 2 times and connect with them and ask them, have you had a breast cancer screening in the last 12 months? Have you been seen in one of our clinics? And then either set them up for the breast cancer screening or bring them in for an appointment. And the appointment, when they come in, the medical assistant tasks it to a referral department who then go ahead and set up an appointment for them for the breast cancer screening. Now, there are always some patients who are resistant to coming in or even having a breast cancer exam done. So we send them a letter. We go through this process, and sometimes there are patients who are just resistant. So, and they want to come in, they don't want to have a breast cancer screening done. So then we have a team of community health workers. So then they step in and they outreach and they talk to them. The most successful strategy has been talking to them on the phone, bonding with them, impressing upon them the importance of breast cancer screening, and not giving up. And then we also have a mobile unit. It comes from Tucson, and they offer free breast cancer screenings. They come here once a year. So that opportunity is also used. They set up their camp on Sunset Health premises, and so the patient population can benefit from that as well. So those are some of the key ingredients of the success story. This success could not have been achieved without the team. It's always the team effort that delivers.
So I want to go back to something that you mentioned a couple times as far as barriers being the patient population not understanding how important this preventative screening is, impressing upon them how important it is. Can you kind of talk a little bit more about what that patient education piece might look like?
Yes, so I have coached my team members. I'll go back a little bit. My first job in the United States was as a telemarketer. So I thought I would improve my English, and I used to work for the American Heart Association, making phone calls to different patients. And our supervisor was a retired Michigan Bell phone company supervisor, and she taught us in those days, 35 years back, always break the ice by some little conversation. How are you doing? It's a beautiful day. And how are the children? How are the grandchildren? Things like that. And that's what I've helped my team members, so they don't run off straight to their lines. We have a protocol on breast cancer screening, what are the things they need to say, but they initially start off by some light conversation, and that helps. We share the protocol. You don't want to frighten them to death, the patients, but you want to encourage them to come in. And the patients, as a small community, they have bonded. They know all of the team members by name by now, and they do come in and they do get the stuff done. And I have my office is separate because besides this work of risk management I have to do, and there are other things that I have to do for the company. So my offices are kind of locked up at times. But you see, the team is doing its work. No micromanagement. We are focused only on outcomes.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.